Welcome to Quick Anatomy. This is the upper limb module and the topic is the scapulothoracic joint. How to navigate through the lecture. The video will play continuously. You can stop the video by clicking pause. You can then continue by clicking play. If a question is asked of you, 1. Click the pause button to think about the answer. Click play to show the answer and immediately click pause to check your answer. 3. Finally, click the play button to go to the next question. You can also use the scroller to move the video forward or backward. Pause if you want to read about the author. Pause if you want to learn how to optimize your learning experience in anatomy. Pause if you want to go through this page. Let's now study the scapulothoracic joint. This is not a true joint, as the movements here are not due to muscles moving two bones joined together at a joint. In the scapulothoracic joint, the scapula is moved by several muscles, each covered with fascia, moving against one another as they contract. Interstitial fluid between the fasciae allow gliding movements to be smooth. A. Introduction. 1. The anatomical position of the scapula. To understand the movements of the scapula, it is important to know the correct position of the scapula on the thoracic wall. Dorsally, the scapula extends from the second rib to the seventh rib. Its medial border is about 5 cm from the midline. Also, the ventral surface of the scapula does not lie anteroposteriorly on the thoracic wall, but rather dorsolaterally. Let's observe what I mean. Let's tilt the thorax backward till we see the superior view of the scapula. Take note that the scapula is located on the dorsolateral surface of the thoracic wall and not anteroposteriorly. 2. The bony landmarks. 1. The external occipital protuberance. 2. The superior nuchal line. 3. The transverse processes of all the 7 cervical vertebrae. 4. The spinous processes of the cervical vertebrae. 5. The spinous process of C7. 6. The spinous processes of the 12 thoracic vertebrae. 7. The posterior border of the lateral 1/3 of the clavicle. 8. The medial border of the acromion. 9. The superior border of the crest of the spine of the scapula. 10. The base of the spine of the scapula. 11. The medial border of the scapula. 3. The thoracic wall. The relevant parts are 1. The costal cartilages. 2. The ribs. 3. The intercostal muscles. 4. The serratus anterior. 4. The ligaments and fasciae. This is the dorsolateral view of the skull and the vertebrae of the neck. A. The ligamentum nuchae. The ligamentum nuchae is shown in green. The ligamentum nuchae is a thin midline fibroelastic membrane. Let's study its attachments. 1. The external occipital protuberance. 2. The external occipital crest. 3. The spinous processes of the cervical vertebrae. 4. The spinous process of C7. B. The thoracolumbar fascia. You will come across this fascia when you study the upper limb because some of the muscles arise from this fascia. We will not go into details at this stage. Note that at the back of the trunk, there is a vertical paravertebral column of deep back muscles. They extend superiorly from the sacral region to the base of the skull. The most prominent of these is the erector spinae. These muscles are covered by a fibroelastic connective tissue membrane called the thoracolumbar fascia. It is relatively thicker in the sacral, lumbar, and lower thoracic regions. Superiorly, it gradually thins out and becomes the deep fascia of the muscles in the neck. B. Movements of the scapula. The movements of the scapula over the surface of the thorax are as follows. 1. Elevation and depression. 2. Protraction and retraction. 3. Upward and downward rotation of the scapula. Let's start with the elevation and depression. Let's see elevation. Let's return to the anatomical position. Let's see depression. Let's return to the anatomical position. Now let's see elevation and depression in a man. Now let's study protraction and retraction. Let's show protraction of the scapula. Let's observe protraction. Let's show retraction. Let's observe protraction and retraction in a man. Let's now study upward and downward rotation. But before we do so, it is necessary to know what is meant by upward and downward rotation of the scapula. A. Upward rotation means the glenoid fossa of the scapula faces upwards. This also means that the inferior angle will move laterally. B. Downward rotation means the glenoid fossa of the scapula faces downwards. This also means that the inferior angle will move medially. To really understand the rotation of the scapula, we also need to know where the axis of rotation is. This is indicated by the yellow rod on the scapula. Let's see animation for the upward rotation. Return to the anatomical position. Downward rotation. Return to the anatomical position. Let's show rotation in man. Upward rotation. Return to the anatomical position. Downward rotation. Return to the anatomical position. C. Let's study the muscles that move the scapula. The muscles are 1. The trapezius, 2. The levator scapulae, 3. The rhomboid major and minor, 4. The pectoralis minor, 5. The serratus anterior. Let's begin with the trapezius. Origin and insertion. Let's outline the trapezius in yellow and remove the muscle. Origin. 1. The superior nuchal line. 2. The external occipital protuberance. 3. The ligamentum nuchae. 4. The C7 spinous process. 5. The spinous processes of T1 to T12 and their supraspinous ligament. Insertion. 1. Posterior border, lateral 1/3 of the clavicle. 2. The medial border of the acromion. 3. The upper border of the crest of the spine of the scapula. Let's insert the muscle. The trapezius. B, the three parts of the trapezius. Let's remove the trapezius. 1, the superior or descending part. 2, the middle or horizontal part. 3, the inferior part or the ascending part. Let's work out the actions of each of the parts. 1, the superior part. The purple arrow indicates the resultant force. Since it is diagonal, it will have two component forces. One will elevate the scapula, the green arrow. The other will retract the scapula, the blue arrow. 2, the middle part. This part only retracts the scapula. 3, the lower part. The purple arrow indicates the resultant force. Since it is diagonal, you will have two component forces. One will depress the scapula, the green arrow. The other will retract the scapula, the blue arrow. C, the trapezius and the rotation of the scapula. This diagram shows the direction of the forces exerted by the superior and inferior parts of the trapezius. Let's position the axis of rotation. There are differing opinions concerning the exact location of the axis. I've chosen the simplified version that is sufficiently accurate to demonstrate the muscles responsible for rotating the scapula. Both parts will rotate the scapula upwards. Let's now study the levator scapulae. A, origin and insertion. Origin, the transverse processes of C1 to C4. Insertion, the medial border of the scapula between the superior angle and the base of the spine. Let's insert the muscle. B, actions of the levator scapulae. The purple arrow indicates the resultant force. Since this is diagonal, you will have two component forces. One will elevate the scapula, green arrow. The other will retract the scapula, the blue arrow. Take note that the levator scapula is almost vertical. This means it mainly elevates the scapula. Question, how will the levator scapulae rotate the scapula? Let's insert the axis for scapular rotation. Now it can be seen that it rotates the scapula downwards. Let's now study the rhomboid major and minor. Origin, rhomboid minor. 1, the lower end of the ligamentum nuchae. 2, the spinous processes of C7 and T1. Insertion, the medial border of the scapula opposite the base of the spine. Rhomboid major. Origin, the spinous processes of T2 to T5. Insertion, the medial border between the spine of the scapula and the inferior angle. B, action of the rhomboid major and minor as a whole. The purple arrow indicates the resultant force. Since it is diagonal, it will have two component forces. One will elevate the scapula, the green arrow. The other will retract the scapula, the blue arrow. What rotation does the rhomboid produce on the scapula? Let's insert the axis of the scapular rotation. They will rotate the scapula downwards. Let's now study the pectoralis minor. Let's see the lateral view of the thorax. Origin and insertion. Origin, the anterior surface of the third, fourth, and fifth ribs adjacent to the costal cartilages. 2. The fascia covering the relevant intercostal muscles. Insertion, the coracoid process. Let's insert the muscle. B. The action of the pectoralis minor. The purple arrow indicates the resultant force. Since it is diagonal, it will have two component forces. One will protect the scapula, the green arrow. The other will depress the scapula, the blue arrow. C. What scapular rotation does the pectoralis minor produce? This is the acromion process. Let's remove it. This is the pectoralis minor, colored in orange. Let's draw a white outline of the scapula. Let's remove the scapula. Let's outline the thoracic wall and remove the picture. Let's insert the axis for scapular rotation. Now you can see the relationship between the pectoralis minor and the axis of rotation. The resultant force of the pectoralis minor is downward, purple arrow. Question, what kind of rotation does it produce? Answer, downward rotation. Let's now study the serratus anterior. Let's see the lateral view of the thorax. This is the lateral view of the thorax. This is the serratus anterior. Let's tilt the scapula posteriorly so that the serratus anterior muscle is fully exposed. A. Parts of the serratus anterior: the superior part, the middle part, and the inferior part. Let's go to the next slide. B. Origin and insertion. The superior part originates by two digitations from the upper two ribs. Insertion, the superior angle of the scapula. The middle part originates by two digitations from the third and fourth ribs. Insertion, the medial border of the scapula. The inferior part originates by 4 or 5 digitations from the 5th to 8th ribs. Insertion, the inferior angle of the scapula. Muscle fibers also arise from the investing fascia covering the relevant intercostal muscles. There are variations in the number of digitations, plus or minus 1. Action of the serratus anterior. Action of the superior part. The purple arrow represents the resultant force. The component forces protract, green arrow, and elevate the scapula, blue arrow. Action of the middle part. Protraction only, since the fibers run horizontally and anteriorly. Action of the lower part. The resultant force, purple arrow, is directed diagonally, so there will be two component forces. One is directed anteriorly, green arrow, and protracts the scapula. The other is directed inferiorly, the blue arrow, which depresses the scapula. Action, rotation of the scapula. This is the axis for rotation of the scapula. This is the inferior part of the serratus anterior. Note that the resultant force, purple arrow, runs anteriorly inferior to the axis. This will result in upward rotation of the scapula. Let's show the animation. This is the upper part of the serratus anterior. Notice that the resultant force, purple arrow, is directed upward and laterally above the axis. This will result in downward rotation of the scapula. Let's show the animation. Notice that the middle part of the serratus anterior plays no part in the rotation of the scapula since its fibers pass close to the axis of rotation. F. The nerve supply of the serratus anterior. The serratus anterior is supplied by the long thoracic nerve, which runs vertically downward along or just posterior to the mid-axillary line and deep to the fascial covering of the muscle. When surgery is performed in the region of the serratus anterior, the long thoracic nerve may be accidentally severed, for example, when removing axillary lymph nodes in people suffering from breast cancer, resulting in paralysis of the serratus anterior. What will happen then? You will get winging of the right scapula. Let's study the muscular dynamics of winging of the scapula. This is a superior view of the thorax and the scapula. Let's draw an orange outline of the thoracic cage and remove the cage. Let's draw a white outline of the scapula and remove the picture of the scapula. This is a cross-section of the skin. Let's insert the serratus anterior. Let's insert the rhomboids and the trapezius. Let's show the resultant force of the serratus anterior, the yellow arrow. The forward component force will draw the medial part of the scapula toward the thoracic cage, the green arrow. The lateral component force will pull the scapula laterally. Let's show the resultant force of the trapezius together with the rhomboids, white arrow. The forward component force will draw the scapula towards the thoracic cage, green arrow. The medial component force will now pull the scapula medially, orange arrow. Notice that the serratus anterior pulls the scapula laterally, while the trapezius and the rhomboid pull medially. Therefore, these forces cancel each other out. However, both the serratus anterior and the trapezius, together with the rhomboids, powerfully pull the medial border of the scapula towards the thoracic cage. That is why normally the medial part of the scapula will glide close to the surface of the thorax. Now, what happens when the serratus anterior is paralyzed? The pull of the medial border of the scapula toward the thoracic wall by the serratus anterior is lost. So the scapula will shift away from the thoracic wall. The lateral pull of the scapula by the serratus anterior is also lost. So the trapezius together with the rhomboids is free to pull the scapula medially. If you were to feel for the medial border of the scapula, you will find that it is displaced somewhat medially. This can be confirmed on a radiograph of the chest. The scapula will be pushed medially, causing the skin to bulge a little. This is called the winging of the scapula. If the winging is not obvious, you can ask the patient to push against a wall or any kind of resistance. The force will push the scapula posteriorly since the serratus anterior is not able to counter this force. The winging will become obvious. The winging is now quite obvious. The left picture shows the winging, but is only slight. The right picture shows the winging on the scapula, and it is very obvious because the patient is pushing against the wall. The nerve supply of the serratus anterior is segmental. Note that the nerve supply is segmental. The upper part of the serratus anterior is supplied by the higher branches of the long thoracic nerve. The middle part of the muscle by the middle branches and the lower part by the lower branches. What is the significance of knowing this? In an upper axillary lesion, all three parts of the serratus will be paralyzed. The winging will affect the whole medial part of the scapula. In a mid-axillary lesion, the middle and lower parts will be paralyzed. The upper part will be intact, but it cannot compensate for the loss of power of the middle and the lower parts of the serratus anterior. The winging will also affect the whole medial part of the scapula. However, in an inferior axillary lesion, only the lower part of the serratus anterior will be paralyzed. The winging of the scapula will affect mainly the inferior angle of the scapula. Observe this in this picture. Congratulations, you have finished the study of the scapulothoracic joint. Let's evaluate how well you have understood this lecture. How to navigate through the questions. When a question is presented to you, 1. Click pause and answer it. 2. Click play for the answer and immediately pause again to compare your answer. 3. Click play again to go to the next question. Pause the video to read these instructions. This lecture is strictly for medical education and is non-profit. Have a good day. See you in the next lecture.